Hi everyone, we're going to talk about cardiovascular problems in Chapter 10. Some of the common complaints that we see with cardiovascular issues are chest pain, palpitations, syncope, dyspnea, leg aches, and peripheral edema. So chest pain can be associated with many different problems. We all think about cardiac, but it can also be associated with GI, pulmonary, musculoskeletal, neuro, psychogenic, and idiopathic causes. If chest pain is cardiac in nature, it has an increased incident for men over 35 and also for menopausal women. There's a very detailed differential diagnosis chart on page 431 regarding chest pain that I'd like for you to look at your convenience. We're not going to go over some of these common complaints, but read about them in the first pages of Chapter 10. So some common problems cardiovascular-wise is hypertension. It is one of the most chronic health problems seen in primary care. 1 in 3 adults is affected by it. For healthy patients greater than 60 years old, per the JNC guidelines, an acceptable blood pressure is up to 150/90. Healthy patients age 18 to 59, an acceptable BP of 140/90, and patients over 60 with diabetes or chronic kidney disease, a blood pressure up to 140/90. Here's the link for the JNC algorithm, and I encourage you to look at that. I'm also going to show you a picture of it here on this next slide. You can see we're not going to go over it, but it's a great algorithm to show you what you need to do, and pretty self-explanatory as you go through it. Here's the second part of it, which talks about different treatment options that you have. Approximately 95% of patients with elevated blood pressure have primary or essential hypertension with no single identifiable cause. There can be an interplay of genetic issues, environmental issues, including lifestyle. About 5% have secondary hypertension, which can be reversible. We aren't going to go into the causes of hypertension, but be sure and review those on page 437. So for your exam of the patient with acute to severe high blood pressure, typically you are not making a diagnosis on a single reading. There's a lot of factors that can go into why someone may have an elevated blood pressure when they present to you in the office. And typically it is more than one, and you're noticing a pattern. We all heard of the white coat syndrome. Usually these patients present and they don't have any complaints. It's an incidental finding that we find. So when you're assessing these patients, have them sit with both feet on the ground with their back supported. Avoid talking with them or engaging with them for anything that might raise their blood pressure, and take 2 separate blood pressures. It's important that you have a focused health history and an exam. Focus on their cardiovascular risk, their age, gender, if they're a postmenopausal status, diet, activity, alcohol or caffeine smoking, their lipid status, if they have a history of diabetes, if they have a family history of heart disease, what current medicines they are on. You need to assess for certain medications such as NSAIDs or over-the-counter cough medicines, which may elevate blood pressure. And then also excessive use of alcohol can lead to hypertension. It's important that you do a fundoscopic exam because hypertension can definitely impact vision. Do an assessment of the PMI, do an abdominal assessment for bruits, and then assess for pedal pulses. Some diagnostic testing for the patient who has hypertension should focus on the evaluation of target organs and concurrent conditions. So you'd want to do an EKG as an important screening tool to assess for cardiac target organ damage. It can also be used to diagnose the presence of left atrial enlargement, left ventricular hypertrophy, an MI, or an infarction, premature ventricular contractions, or AFib. Some of these are the earliest will be seen on earliest EKG findings associated with hypertension. So as we talked about, evidence of target organ damage that can be caused by high blood pressure, you could have papilledema or hemorrhages in the eyes. You may see changes in mental status or neurological deficits. Your EKG may tell you about some ischemia to the heart muscle or an infarction. Chest x-ray may show heart failure or aortic dissection. And renal dysfunction may be seen by hematuria, proteinuria, and elevated serum creatinine. On this slide, we have some different images of the heart as some different processes are going on. Here on the left, you can see what a normal heart would look like. We have an aortic aneurysm, and you can see how the aorta is beginning to bulge there. And then for an aortic dissection, you can see this clot that's working its around that's going to bifurcate that aorta there. Some lifestyle modifications to manage high blood pressure would include weight reduction, dietary changes. Often we are suggesting the DASH diet, monitoring your sodium, increase physical activity, alcohol in moderation, and to stop smoking. And you can find more about that on table 10.2 on page 433. Some pharmacological therapies for high blood pressure. JNC8 recommends 4 classes of drugs for first line and then later line treatments. The first being your thiazide diuretics, then calcium channel blockers, your ACE, your ARBs, and then they also recommend higher doses or combinations of these medications for second and third line alternatives for hypertension. Some medications that you might consider for later line alternatives would be beta blockers, alpha blockers, vasodilating beta blockers, direct vasodilators, loop diuretics, aldosterone antagonists, and peripherally acting adrenergic antagonist. And in your book on that pharmacological table, this will give more detail on all of those. Also, when determining your medication regimen, patients of African descent without chronic kidney disease should use calcium channel blockers and thiazides instead of ACE inhibitors. I believe we all know that the African American population typically needs to be treated with more than one blood pressure medication, that they're very resistant to therapy. So ACE and ARBs are recommended in all patients with kidney disease regardless of their ethnic background, and ACE and ARBs should not be used together. Calcium channel blockers and thiazide type diuretics should be used instead of ACE and ARBs in patients over 75 who have impaired kidney function. So the next thing we're going to talk about is metabolic syndrome, and it's a cluster of specific cardiovascular disease and diabetic risk factors that are thought to be related to insulin resistance. Metabolic syndrome is characterized by increased body mass index and seen in the abdominal area, elevated systolic blood pressure, increased triglyceride levels, elevated blood sugar, and low HDL. With any 3 of these conditions occurring together, it can establish the diagnosis of metabolic syndrome. Obesity is believed to contribute significantly to the development of metabolic syndrome, and a high waist to hip ratio can indicate abdominal obesity. Weight loss improves lipid profiles, reduces blood pressure, decreases insulin resistance, and also improves glucose intolerance. So that's why it's important to help decrease those weight numbers to help with other parts of the metabolic syndrome. Dyslipidemia, also known as hyperlipidemia, is a general term for elevated concentrations of lipids in the plasma. When individuals have this, they're at a major risk for cardiovascular disease. Increased lipid levels correlate to a growing risk of acute coronary syndrome, which we know that elevated lipids present the greatest risk of coronary artery disease, based on the Framingham Heart Study that documented 40% of patients who developed an MI had a total cholesterol between 200 and 250. And then a patient with a total cholesterol greater than the 259 level is 3 times more likely to develop coronary artery disease than a patient with a level less than 200. We also know that dyslipidemia is a heterogeneous metabolic disorder that has increased levels of lipids and lipoproteins that can increase your risk of atherosclerosis. So here are what are considered desirable lipid levels, so you can review that. So when trying to initiate lipid-lowering therapy, um, these patients may present without symptoms, but they also may have other issues such as hypertension or CAD. And so on physical exam, you may notice a carotid bruit or a corneal arcus in the eye. And in some forms of dyslipidemia, you can notice a yellowish skin deposit of cholesterol in the corners of the eye that are called xanthomas. And these are commonly found and don't respond to lipid-lowering products. Okay. Therapy should be initiated when a patient's 10-year risk for first atherosclerotic cardiovascular disease event is at 7.5%, and the way to calculate that is at this website, so you can go over that at your convenience. So for dyslipidemia management, the thought is giving statins, and so based on your previous calculation on the slide before, you will determine whether they are at what risk they are and what statin is needed. And so high intensity statins are considered like your atorvastatins at higher doses, like 40 to 80 milligrams, or your rosuvastatins at 20 to 40 milligrams. Moderate intensity statins include the above drugs, but at lower dosages, and they also include like your pravastatin, simvastatin, and lovastatin. And on page 453, you can see a table of common drugs. Also, as we talked about earlier, the management of dyslipidemia is so dependent on diet. And it's important to provide ongoing support to patients when making these changes, and also on starting pharmacological therapy. Showing patients lab results and having discussions about what the numbers mean is very helpful, and I think something that nurse practitioners do very well. Show them what their numbers have been if you're starting them on a statin, or have made an adjustment with exercise and nutrition to see where their numbers have gone. It helps them as a way to see the benefits of what you're trying to do. Also, have calculating the CV risk or starting a conversation about them. The need for statins is also very beneficial on getting them on board for what they need to embrace with that. So let's talk a little bit about coronary artery disease, atherosclerotic coronary artery disease. It's the leading cause of death in the U.S. and is responsible for more than 1 in 4 deaths, which turns out to be approximately 60,000 deaths per year. Mortality has declined over the years because of patient education regarding risk factors and the recognition and treatment of early symptoms. Some modifiable risk factors include hypertension, smoking, sedentary lifestyle, hyperlipidemia, and for women being menopausal without estrogen replacement. For some non-modifiable risk factors that we can't do anything about includes gender, being male, increasing age, family history of coronary artery disease, and being African American. Coronary artery disease develops many years before the patient is aware of its existence. The body is developing collateral circulation, so that the patient is usually unaware that anything is wrong. Typically, symptoms of CAD are not reported until 75% of the coronary artery is narrowed. And that's when you may start seeing associated symptoms may include radiation of discomfort to the left arm and jaw, nausea, shortness of breath, or lightheadedness. Objectively, you should check for peripheral pulses, auscultation of carotid bruits, assessment for any jugular venous distension, taking blood pressure sitting, lying, and standing, and examine the skin for evidence of decreased perfusion. And then some other contributing factors to CAD include diabetes, obesity, and stress. So some diagnostic tests that can be used for coronary artery disease include an EKG, a stress test, nuclear scanning, and angiography. These may be used to determine the extent of the disease and to identify which vessels have been affected. Stress tests increases the myocardial oxygen demands, which helps evaluate coronary arteries' ability to meet the increased demand successfully. Nuclear scanning studies check the motion of the left ventricular wall, and measure the ventricle's ability to eject blood, which is known as the ejection fraction, which is normally anywhere from 55 to 75%. Contrast enhanced CT is a non-invasive image that assesses the overall plaque burden in the body. Cardiac cath is commonly performed for patients that have a high risk of acute coronary syndrome. It offers visualization of the arteries to confirm diagnosis of CAD, and it can also evaluate the extent of stenosis that is seen. Ultrasonography also measures plaque burden. Because arterial sclerosis is a chronic inflammatory condition, a CRP is commonly elevated in these individuals that have CAD. And then epidemiological studies have shown that elevated levels of homocysteine is an independent risk factor for atherosclerosis and CAD. In the management of these patients, it's very important to include risk factor modification to stop the progression of the disease. It's important to aggressively provide treatment for lower lipid levels and to have a tight glycemic control of the patients with diabetes. Pharmacological agents are used to control symptoms of angina and to prevent subsequent events. Most clinicians recommend low-dose aspirin to decrease the incidence of a first MI. Coated aspirin is recommended. It's important that the patients understand that this is a chronic disease and will require frequent follow-ups to control risk factors. These patients should also be referred to a cardiologist for a stress test and any other cardiac workup. On each visit, when these patients see you should stress risk factor modification to manage hypertension and to promote overall cardiovascular health. We're going to talk briefly about coronary artery syndrome, and then we'll break and start a new video of this. So for acute coronary artery syndrome, there's several disorders of the myocardial ischemia. You can have stable angina, unstable angina, variant angina, which is Prinzmetal's angina, and then of course an MI. So some diagnostic tests. Acute coronary syndrome is used for disorders of myocardial ischemia, and these, as we talked about, include the stable, unstable, variant, and myocardial infarction. Stable angina is diagnosed as a condition of ischemia that is predictable in pattern, of frequency, and controlled with meds. Unstable angina is myocardial ischemia that is newly diagnosed or previously diagnosed angina that is changed in pattern, frequency, or severity. And MI necrosis, or death of the part of the myocardium, can happen as a result of prolonged ischemia. The best lab test to rule out for cardiac issues are cardiac specific troponin 1 and a t-test. Cardiac troponins are cardiac proteins released from the heart muscle and are not detected in the blood of a healthy individual. These levels rise within the first 2 to 4 hours after an MI and may remain elevated for 7 to 10 days. Serum cardiac enzymes also include the specific MB, iso and serum creatine phosphokinase (CPK). These levels rise within 48 hours after an MI, and then they gently return to normal by 48 to 72 hours. The myoglobin is a muscle protein that rises in the blood with only a few hours after an MI, and is one of the earliest serum cardiac markers to rise after an MI. However, it's not specific for just cardiac muscle death, and it can rise with skeletal muscle injury. And then other labs would include a CBC, a SED rate, electrolytes, BUN, and creatinine. The last slide that we'll go over in this deck is a graph drawing of EKG evolution in a non-reperfused MI, and you can see how we have our normal EKG tracing here. In minutes after the MI, we can have a peaked T wave. We have progression of the ST segment elevation in minutes to hours. In hours to days, we can have the loss of the RV wave and Q wave formation. And days later you can see a T-wave inversion, and then days to months later you can see the T-wave normalization and a persisting Q-wave. So we're going to stop here and we'll come back in our next video and talk about chest pain.